to Sarah.
Hi everyone, thanks for joining. So my name is Sarah Gregory and I am a diabetes specialist nurse, and I've worked across primary, secondary and community care, community services. So a bit of an overall all-rounder, and I now primarily work in primary care, as well as delivering on the Pit Stop Foundation and injectable course. So do ask any questions as we go along. I can't see the chat when I'm presenting, but whatever we don't address throughout the presentation, then we can pick up at the end of that. The presentation is aimed primarily at people living with diabetes. So if you are a healthcare professional and you're listening in, hopefully it'll be useful to you, and how we portray and explain what HbA1c is. Okay, now just to give you the heads up, I'm on quite an old laptop, so I'm hoping that my presentation will see the duration. If it doesn't, you'll just see me again while I reload the presentation. So the wonders of technology. Okay, so I'm just going to go into the presentation. So this is being recorded, and we can address any questions at the end of the presentation. Okay, so where am I? So let's go over. Just close that chat down. So we're going to talk about HbA1c, what it is, and why it's important, because this is something that you'll hear all the time when you're having your checks for diabetes. Okay, and I still see a lot of people that don't understand what HbA1c is and how it compares to their finger pricking, for example. So hopefully by the end of this, we should have quite a good idea of what HbA1c means when we're setting targets and in relation to finger pricking as well. So HbA1c, and this has come from Diabetes UK, their explanation, and it's called the hemoglobin. So hemoglobin is your red blood cells, okay? And it measures how much glucose, blood sugar, has attached to your hemoglobin during that period of that red blood cell's life, okay? Hemoglobin is the part of the red blood cell that carries the oxygen from our lungs to the rest of our body. So for those of you who did biology many moons ago in secondary school, this is the bit that gets the oxygen to everywhere it needs to go. Okay, now we can use HbA1c to diagnose type 2 diabetes. Okay, we'll talk a little bit about when we don't use it for diagnosis, but we also use HbA1c to monitor our ongoing diabetes management. Okay, and we're going to talk about targets and what that means when we're setting those targets. So it is measured differently to the blood glucose levels you see if you prick your finger. So when you prick your finger, you get a level, and that's what your glucose is there and then. The HbA1c is an average of all those thrown in a pot, mixed together, and it comes out with an average. That's the best way to try and understand how it's different. So when we do the HbA1c blood test, we do it with other things as well. We don't normally do it as a standalone, because it's important that we make sure people aren't anemic and things, because that can affect the result of the HbA1c. So what we're measuring is how much glycemia, glucose, has stuck during the life of a red blood cell. Okay, so a red blood cell, you can see at the bottom here, the erythrocytes survive around 117 days in men, 106 days in women. So we do an average of around 90 days for HbA1c. Okay, so it's a blood sample with a mixture of those older and younger cells. So if you have a HbA1c, you'll notice that you won't get tested again for at least 3 months, because otherwise we're retesting some of those cells that we've already tested. Okay, so glucose in the last 30 days accounts for approximately 50% of that HbA1c result. So if you're newly diagnosed, or you've been really unwell or really poorly in the last 30 days, that could affect your overall HbA1c more significantly than these ones of 30 to 90 days. Okay, so if you go on holiday for 2 weeks, that's not quite the same. Okay, so don't be discouraged from having your HbA1c because it's Christmas or it's Easter or it's a birthday or you've been on holiday, because still 40% of that is measured between 30 and 90 days. Okay, but that's how it's made up. And that's what we're measuring when we do your HbA1c. So when we use HbA1c to diagnose somebody with diabetes, we don't do diagnostic with everyone with a HbA1c. Now, the World Health Organization, do recognise that HbA1c is an alternative diagnostic test for some types of diabetes. Okay, but we interpret it with caution. So if you've got an abnormal red cell turnover or an abnormal hemoglobin type, that will affect the measurement of hemoglobin that we're going to get with glucose stuck to it. Okay, so if you're severely anemic, or if you've got an altered lifespan of that cell, recent blood transfusion, they won't be testing your blood, they'll be testing somebody else's. And also if there's a sickle cell trait, the sickle cell are very different shape to an ordinary red blood cell, so they don't attract glucose like our standard blood cells do. So we use it with caution when we're diagnosing people with diabetes. Okay, now we do use it to diagnose people with type 2 diabetes. If one of you came along and I did a random HbA1c on you, you had no symptoms, then we might repeat that within 2 weeks with a note to the lab saying, no symptoms, HbA1c this, can we repeat? Otherwise, they won't repeat it for 90 days. If you get a HbA1c signifying diabetes or pre-diabetes and you're symptomatic, then we don't need to repeat that. Okay, so we don't use HbA1c in people with type 1 diabetes, not to diagnose. We use it as a baseline marker for when those people are diagnosed, but we don't use HbA1c on its own to diagnose type 1 diabetes. So this applies to children and young people. So children and young people under 18 years of age, because there's a slightly different changeover of red blood cells. So we use it as a baseline, but we don't use it to diagnose. We don't use it to diagnose pregnant women or women who are 2 months post-delivery, because remember that we are measuring cells over red blood cells over 90 days. So if women who have had gestational diabetes, for example, if we tested them a month after, they might still have some of their old red blood cells when they had gestational diabetes. Okay, so with pregnant women, we do the glucose tolerance test. Okay, if people have had symptoms of diabetes for less than 2 months, again, because it's not that 90-day cycle, we would use it as a baseline. We wouldn't use it to diagnose, and we would do a fasting or a random glucose level at the lab. If people have a high diabetes risk or acutely ill, we don't use it to diagnose. Again, we use it as a marker. And if people have been on steroids, for example, we would measure their HbA1c, but we wouldn't use it to diagnose them. Okay, and also people with acute pancreatic damage, including pancreatic surgery, we wouldn't use HbA1c to diagnose that type of diabetes. And also we don't use HbA1c with end-stage renal disease or HIV, because we know that they are often more anemic, so we're going to get a false result of that HbA1c. Okay, so if we go on to the diagnostic criteria, now you can see on here I've circled our diabetes ranges there. So if you have a HbA1c done and it comes back at 47 or above, or 48 and above, you have diabetes. Okay, we're talking about type 2 diabetes now. Okay, if we do a random glucose and that comes back at 11.1, there is diabetes there, but we might be looking at pancreatic diabetes, gestational diabetes, or type 1 diabetes. And that's a random glucose anytime 2 hours after a meal, okay? And then a fasting glucose anywhere above 7 is a diagnosis of diabetes, okay? So you can see that there's different blood tests and different ranges that we use to diagnose people with diabetes. HbA1c is one of them, but it's not the only thing that we might use. Okay, and then your orange circles is what we call that non-diabetic hyperglycemia, or you might know it as pre-diabetes. Okay, so this is where you haven't got that diabetic range, but you're not within this normal non-diabetic range. Okay, so we know that these people with pre-diabetes or that non-diabetic hyperglycemia are more at risk of going on to develop type 2 diabetes. So there's a lot more screening around how we stop that transition into type 2 diabetes. So we use HbA1c also as a measurement for our ongoing diabetes management. So all of you, everybody with diabetes, doesn't matter what type of diabetes, need to have an annual review within primary care. Okay, primary care are the services commissioned to deliver those 9 key care processes. Well, 8 of them. The 9th one, the retinal screening, is provided by local eye screening services. But all of the other checks with your diabetes, HbA1c, blood pressure, cholesterol, foot assessment, urine ACR, EGFR, BMI, smoking status, that is primary care's remit. So even if you're going to the hospital or the community service and seeing specialists, your GP service and surgery will provide that annual review. Okay, and they are general practices commissioned to provide that for everybody with diabetes. So HbA1c is part of the annual review, and surgeries do it differently. So in the surgery that I work in, it tends to be all this annual review with a foot check, with a blood test, and then see me as a specialist. With some surgeries, you might get your bloods done on one day and have your foot check on another day and have a medication review on another day. So, but it's important that you do all of those processes so that you know what your HbA1c is. And I know Diabetes UK are doing sessions on kidneys as well. And if you get the chance, please do attend those, because HbA1c is only one of those key care processes. Okay, and they're all as important as each other. So if we look at HbA1c levels, now I'm not sure, it depends on how big your screen is, okay? This is a really good resource. And when we do pit stop teaching, which is education for healthcare professionals, we use, and I use this in practice an awful lot, because this allows us to talk about targets. And it's really important that when we talk about targets, that they are individual. Okay, so the guidance and the NICE guidelines and all the evidence points to having as good as HbA1c as we can achieve. Okay, so we in our heads as healthcare professionals, we've got what we're wanting to achieve. Okay, but they should be individual. So now, if I'm hoping this pen works. Okay, the pen normally works, but it doesn't always like being told what to do. Let me just change the pen colour to, okay. So, for example, if someone came to see me, okay, and they had a HbA1c of, let's say, 86, okay, you can see that that's in the red zone. Okay, so traffic light systems work really well. This is traffic light systems and a bit more, because you've got a bit of blue in there and all. So, but we know that in the red is where we are going to see that increased risk of complications. Okay, so if someone came to me with a HbA1c and you were feeling symptomatic, I would ask, okay, so we can see you're here in the HbA1c of 86. Ideally, depending on your age, depending on your circumstances, we want a target of at least 58, maybe below if you're a young adult with newly diagnosed and's got the potential to make those changes. So, but that's a long way to come from 86 all the way to 58. And we wouldn't expect people to make those changes dramatically. Because if we have a sudden big drop, that might actually make you feel worse. Okay, and then you won't come back and see me again because you'll say, well, Sarah put me on these tablets, told me what to do, and I feel awful. So it's about setting those individual targets. So I might say to someone with a HbA1c of 86, let's go for a 20% drop. That way, we're going to protect your eyes because the vessels behind the eyes are really sensitive to glucose changes, up or down. Okay, so we don't want to increase, we don't want to get you to 58 straight away because that's a 30 millimole drop. That's a big drop. That's over 50, that's, nearly sort of 40%. Okay, so let's aim for a 20% drop. And for the next 3 months, let's work at getting a target to 70. Okay, so 20%, 8.6 is around 17. Okay, so let's get you to this target. Or you might say to me, actually, Sarah, you're saying 70, but can you put me in that orange and let's go for HbA1c of 69. Okay, and then we work on that and we look at how we're going to achieve that. Okay, you still consider your final target because we know there is evidence that the better your diabetes numbers are, the reduced risk of complications. And always ask what your HbA1c is. Okay, and whenever I see people or I do telephone or video consultations, I'll always send them a little Accurix text saying, this is your HbA1c, or can you write this down? I'm going to tell you what it is, write it down. This is what we're aiming for. Okay, so that's a really easy way of setting people's targets. Now, if I say to you a HbA1c of 69, you'll say, okay, what's that when I'm pricking my finger? Okay, so we have these lovely little comparison charts. And if you said to me, look, I don't normally prick my finger, but I really want to achieve this target, I'm happy to prick my finger, I might say to you, okay, let's work on your fasting glucose. Let's check your glucose before breakfast, okay? And with a just check my pen, with a HbA1c target of 69, we want your fasting breakfast levels between 7 and 9. Okay, so that's not too low because at the moment they are probably between 9 and 11. So we're not asking for a massive drop. Okay, now to get that pre-bed reading, we add 2 on to this lower number, so that would be 9. Okay, and we add 3 on to this number, which is 12. Okay, so your pre-bed readings could be 9 to 12, and that might make you feel comfortable about making those changes because I'm not asking you to come down to a low glucose level that you might feel you can't manage. Okay, so you can see here also gives average glucose levels. So for HbA1c of say 64, we're asking for an average of 10. So for 69, that's probably going to be about 10.5 for our HbA1c of 69. Okay, so then you've got targets. So when you're pricking your finger, you know what you're aiming for. Okay, and if it's above those targets when you come back to see me in a month or I call you in a month, then I might say, well, let's adjust this, that, and the other. Okay, now the targets for older people or those with frailty are more relaxed, and that's because of the risk of hypoglycemia. So for somebody with living in a care home or a nursing home, we would say, well, we don't want to get you to 58. We would be happy, here we go, 64 to 69. We're happy with that. You could still look at your glucose levels on a daily basis, how we achieve that, but we're not going to be so strict because we're going to cause more problems if we titrate things too much. Okay, so hopefully that makes sense. So, and this is it in another chart. Okay, so so for a HbA1c of 69, here's your, oh, hang on, here's your pre-breakfast readings. Let me get my pen back. Here's your pre-breakfast readings of 7 to 9 and your pre-bed readings of 9 to 12. Okay, at 86, you can see we're dropping those by a couple of millimoles. That's all. So then we want to get to 58, then we're going to say pre-breakfast 5.5 to 7.5, pre-bed 7.5 to 10.5. So we're still avoiding those hypos, okay? And I quite often give people this and set it out for them. So they go away with something that they know they're aiming for, and as a reminder, because they don't always remember what everything we talk about in a consultation. So HbA1c are individual, okay? We're talking about type 2 diabetes now, okay? So 53 to 58 is the gold standard. Now, if you're a young adult under the age of 40 with newly diagnosed type 2 diabetes, we're going to ask for 48, okay? Because you're going to be living with diabetes for longer. Okay, so those risk of complications are already going to be higher because you're living with diabetes for longer. Okay, so at diagnosis, we would be saying, I may be on one or no oral agents. Let's go for 48. Okay, and that could be somebody who's over the age of 40 that comes to me and says, Sarah, this is a real shock to me. This is a real wake-up call. I want to get to as low as target as possible and feel well for it. Okay. Now, if we start drifting that HbA1c towards 53, that's when we might add in another agent. So we're talking about another tablet. Okay, because the UK PDS, which was this massive study almost 30 years or 40 years ago, 40 years ago, can't do my maths, that mean HbA1c of 53 millimoles showed this greatest outcomes with little hypoglycemia. Okay, so 53 is our gold standard. Okay, so then if you start drifting up to 58, which in the UK PDS study was an average HbA1c, we don't want you going above that because we know that at 63 millimoles, we started to see quite a significant increase in complications. Okay, so these numbers are really important. Okay, and you know, some people do hover around 60, 61, think I feel okay, I feel fine, but the studies show 53 to 58 is what we're looking for. Okay, unless you're functionally dependent or frailty or living in a care home or nursing home, and you know, just by default you're more vulnerable or at risk, we would set that. It says 58 to 75, but generally we would say 58 to 69, really. Okay, that's what we're looking for, because you're not going to get hypos, but you're not going to get those osmotic symptoms of raised glucose levels. Okay. So when we talk about type 1 diabetes, the targets are still very similar. We ask for slightly tighter targets with type 1 diabetes, okay? Because the risk of hypos is still there, but with the new technology particularly, we know that we can achieve 48 millimoles without increasing significantly that risk of hypos. But again, it's important to go towards an individualized HbA1c target. So the same as anybody coming in to see me, if someone with type 1 diabetes had a HbA1c of 86, I'd do it in exactly the same way, because it's important that you reach that target safely and you know what the plan is. Okay, we have to take into consideration people's daily activities, their aspirations, their likelihood of complications, and any other comorbidities, their occupation, and also a history of hypoglycemia. Okay, so we know that with type 1 diabetes particularly, they are walking the tightrope. So aiming for HbA1c target, but avoiding problematic hypoglycemia in the waking hours with people with type 1 diabetes. Okay, so you might have heard of continuous glucose monitoring, which is a sensor that people with type 1 are all entitled to now. Okay, so this, we call this CGM. It's now a standard part of type 1 diabetes care, and it looks at targets different to HbA1c, because you can see from HbA1c all we're doing is getting an average. Okay, we're not getting what that time in range is, because that average includes low glucose levels, good glucose levels, high glucose levels, off the scale glucose levels, all put into a pot and give us an average. So the CGM and the time in range is a different way of looking at diabetes control and management. Okay, generally a time in range of about 70% equates to HbA1c of around 48 millimoles. Okay, and if somebody is on a CGM, we still have to do a yearly HbA1c, because it's still measured as part of the QOF, those quality targets in your annual review. Even though on CGM we see a predicted HbA1c, and then there's not much difference in them, but you do need for your annual review to have a lab HbA1c. So this is in comparison, okay? So this is adapted from Abbott, who make the Freestyle Libre, okay? So you can see that if you've got 90% time in range, your HbA1c probably is going to be around 32. Now that might be different, because if 10% of those are all above 13, that HbA1c will be higher. Okay, but this is given an average. So this is working out with some very clever scientists what their predicted HbA1c will be. And you can see that the lower time in range, the higher the HbA1c. Okay, and again, the HbA1c may fluctuate depending on those readings outside of that time in range, whether they're high or low. So somebody might have 90% time in range, but 10% of that time in the evening when they're watching Coronation Street, they are 15 to 16. So they won't have a HbA1c of 32. It's more likely to be closer in the 40s. Okay, but this is just an average that we're giving. Okay, so it's a good marker to what they can expect when they go and have their lab HbA1c. So I've gone through that fairly quickly. Hopefully there's some questions, but just remember that it's a useful tool, and that's what it is, okay? It's not the be all and end all. It shouldn't be used to beat you over the head about your diabetes, okay? So we use it to diagnose some types of diabetes, and we use it to monitor glycemic control as part of that annual review. It's only an average glucose, so we know that it can be affected by this, and it can be affected by some types of blood disorders or anemia, okay? And people living with diabetes, you really do need to know what your HbA1c is, okay? It's your diabetes, so please ask what your HbA1c is, and have those targets discussed with your healthcare professional. So don't go in and be told what your target is. We can tell you what your target we would like to be because of those reducing risks, but your HbA1c and your target are yours. Okay, it's your agenda. And so we then also did a timing range with those with type 1 diabetes on CGM. Okay, so all of these add up, they all form part of the puzzle. Okay, so that's a whistle-stop tour of HbA1c. So I'm just going to end that show, okay, end that PowerPoint, and I'm just going to go into the chat and see if there's any questions in there. Let me have a look.
I've written down the questions for you, Sarah, if that makes it easier.
Yeah.
Okay, so somebody has said, I understand that when somebody has HbA1c 48 or above, they are diagnosed as being diabetic, not below. Please could you explain why in the previous diagram mentioned that 46 or above the person is considered diabetic? I think that was around about slide 6.
So it was around slide 6, and I think it's the slide. So anywhere between 42 and 47 is what we, and I'll simplify, it's pre-diabetes. Okay, you might see it called non-diabetic hyperglycemia. Okay, and there's several other phrases for that as well. I think there's about 9 different read codes, but we tend to use pre-diabetes when explaining it to people who've just been diagnosed, or you might be coded on your GP system as non-diabetic hyperglycemia. So it's not in that diabetic range, but it's in that range where you've got hyperglycemia, okay? But not enough to tip you into that 48 millimoles and above, okay? So I think it might have been the diagram, but 42 to 47 is pre-diabetes. Anything below 42 is non-diabetes range, okay?
Great, thank you, Sarah. Another question, should the normal HbA1c readings be the same across the board, or do we need to see this differently for people from different ethnic backgrounds?
Not from ethnic backgrounds, no, but like we've said, people will have individual targets that they need to agree on what's going to suit them. Okay, so I would never say to somebody, you've got to get to a HbA1c of 53. I would say why I picked the number of 53 or 58, because there's evidence there, but it doesn't matter what ethnicity you are. The only thing that affects that target setting is other comorbidities, frailty, or that individual's choice. Okay, so somebody might say to me, do you know what, I've run a HbA1c of 65 for years, I feel fine, I don't want to come any lower. And that's their choice. Okay, it's still a responsibility of the healthcare professional to tell them the risks of running at 65, but at the end of the day, it's their choice. But it's irrelevant of whether you're male, female, or whatever race or ethnicity you are. It's the same across the board.
Lovely, thank you. I've got a comment here from Claire. Not sure how much we'll be able to discuss this one. Claire says, I'd like to discuss the lack of some hospital teams not warning patients of the risks to your eyes. I have severe retinopathy and was not once warned when tightening my control. It was nice of you to mention this earlier, so thank you for that.
Yeah, and that's a good point. And retinopathy is a microvascular complication, okay? Now, quite often, particularly with type 2 diabetes, you might not know you've got type 2 diabetes for a number of years. That's why all the screening programs are in place now. But we still miss a lot of people. And Diabetes UK would tell you if we've still got a missing million, which we used to have. And that's why we've started coding for pre-diabetes. Now, I have seen people diagnosed with type 2 diabetes and already have established complications, okay? The retina and those tiny little vessels behind the eyes are very susceptible to glucose changes, okay? So if people have retinopathy on diagnosis, it's probably because their glucose levels are high, okay? Now, if we dramatically reduce those glucose levels, and there's certain drugs for type 2 diabetes that have got a warning on us not using them because we see significant drops in glucose levels. And the eyes are very susceptible to those changes because they make these new vessels that aren't great, and those new vessels can obscure the retina or obscure the macula, but they're quite friable, so they're not strong vessels. So, and they are very sensitive to any changes in glucose. So when we teach on pit stop, for example, we always emphasise the fact that if somebody's got a really high HbA1c, even if it's over 100, we wouldn't get that down straight away. We would still only reduce that by 20%. Now, you know, there's probably loads of evidence to support that. There's a really good, like, one-pager thing on Diabetes UK about that. But that's around knowing how sensitive the retinal cells are. And Claire, not everybody is, you know, you've got to remember that not everyone's a specialist. And so if you go for your eye screening, they are the best people to ask, okay, and or ask for information on them. But that's why, and it is important that if you, and you'll see it in pregnancy. So the biggest, what alerted us to this was in pregnancy, people who were planning a child, planning a pregnancy, suddenly improved their glycemic control very quickly, and we saw rapid deterioration in those retinal vessels. Okay, so then we know that that happens with people who aren't pregnant or planning a pregnancy, that any changes affect those really small vessels behind the eye. So it is an important thing to be aware of. Okay, and it, you know, you're right that if somebody's doing retinopathy or retinal screening, you should be able to ask them. But unfortunately, not everybody are special. If you ask me about family planning, I wouldn't have a clue. But I would hopefully be able to direct you to someone who would. Okay.
Thanks, Sarah. That's it for questions. We do have lots of time left, so if anybody does have any questions, please pop them in the chat.
Okay, so type 1 diabetes is, but the reason there's a high amount of sugar or glucose in the blood, Linda, is because of the lack of insulin. Okay, so we always make sugar. Okay, we always make sugar. That's what we do. We, you know, our liver produces sugar, our pancreas produces insulin, our insulin carries that sugar into the cells. So the reason you've got a high amount of sugar or glucose in your blood is because it's not getting where it should be. So it's not getting to those cells. Okay, so with type 1 diabetes, you'll get symptoms a lot quicker and a much more vivid onset of type 1 diabetes. You will know about it. With type 2, it's quite insidious because you are still making insulin. So you're right that type 1 diabetes is a lack of insulin or a much reduced amount of insulin because the pancreas, the beta cells aren't producing that. But it's because it's measured on sugar or glucose because that glucose is where it shouldn't be. Okay, so hopefully that's explained that. Any other questions?
Nothing specific yet. A few people have asked if the slides and the charts are available to be shared afterwards. Are you happy for us to share the information on your slides, Sarah?
Yeah, absolutely.
Fabulous.
Absolutely.
Okay.
And that's a really good point about Simone, actually. Now, without being too complicated, okay, the reason that you feel addicted to sugar is when you first develop, or when the system starts going wrong with type 2 diabetes, you are still making insulin. Okay, so if you have sugary foods or carbohydrate foods which turn to sugar, initially your pancreas will produce more insulin to manage that. Okay, now it might produce too much insulin, which then makes you think, I need sugar because I feel low or I feel shaky. Okay, the other thing that happens is when you've got too much insulin, too much sugar in your bloodstream, it goes into your liver and it sits in your liver. And if your liver doesn't use it, it turns to fat. So a lot of people with type 2 diabetes may have been diagnosed with a fatty liver. Okay, and that's because the liver can't cope with the amount of sugar that's in it. So then what the liver does, thinks, do you know what? I don't want all this fat in my liver. I'm going to pass it on to something else. Okay, so it puts some of it into your subcutaneous tissue and it puts some of it into your pancreas. Okay, which will then inhibit the amount of insulin that you're producing, because instead of being a gush of insulin when you need it, it'd be like a little bleh, like bleh, half an effort. Okay, and that starts happening up to 5, 6, 7 years before you're diagnosed with diabetes. Okay, so by the time you're diagnosed with diabetes, your pancreas might only be functioning on 50%. Okay, but what it does do, it gives you too much insulin when you don't need it, and then that makes you want more sugar. Okay, so Simone, it's almost breaking that cycle, okay, because and sugar is addictive. Okay, there's no doubt that sugar's addictive. Okay, and carbohydrates turn to sugar, so they're addictive. So it's just about looking at, okay, when I have those sugar things, what else could I have? Okay, there's lots of alternatives, and it depends where, you could, diet is a whole day's thing on diabetes. We would say have a little bit more protein rather than carbs, but monitor the calories. So again, it's walking a tightrope, but that's why you feel addicted to sugar, because your pancreas is still working and it might be initially producing a little bit too much insulin before it gets fed up. Graham, type 3C is pancreatic related. Okay, if you've got type 3C, the only treatments we're going to give you is metformin and insulin. Okay, and it should be coded as type 3C, pancreatogenic diabetes, and there is a code on your GP system to code that now. Okay, so, but LADA, are you saying LADA? So it's with LADA, that's like a slow onset type 1. Okay, so you could do a whole session on different types of diabetes as well. But type 3C is pancreatic. So that's pancreatitis, pancreatectomy, pancreatic cancer, any of those fall under that type 3C. And you're generally on Creon because you've got malabsorption as well. Okay. And yes, if you're diagnosed type 2, if you want to go into remission, get that HbA1c below 48, you can do it, especially in the first year. And there's a lot of evidence on the Diabetes UK website about remission. And if it's something that you're really keen to do, Jane, or give advice to your patients, the sooner the better. Because you've got to remember that some people with type 2 may have had it for 5 years and not known. Okay, that's seen less and less likely, but you can come off metformin and glycoside. And just as a aside, glycoside spanks the pank. Okay, glycoside makes that pancreas work harder. So really, it's only a short-term drug, really, to get those glucose levels down before you can start thinking about anything else. Okay, so you can definitely come off your medication and insulin, particularly in the first year, up to 6 years. The work that Roy Taylor's done, that Diabetes UK funded, so there's loads of stuff on Diabetes UK remission. They're saying 6 years maximum, first year is the most successful. Okay, yeah, the pit stop colour scheme is different. It just came out different on the slides, Leah. So normally it is green or blue, orange, and then red. So it's just the way it came through on the slides, I think, on the template. So well spotted.
I've got another question, Sarah. This one's come through to me. So Chaz has asked, my diabetic eye test is going to every 2 years, I assume to cut costs. My diabetes is well controlled. What should I be aware of if I now have a 2-year check?
They would have done that on good clinical evidence as well. So with the diabetes eye screening program is probably one of the most successful screening programs, along with cervical smears and breast screening. Okay, because we very rarely see people losing their sight. I haven't seen somebody lose their sight for diabetes for many years. Okay, and also the degrees of retinopathy that you get is becoming less and less. So it's not about a cost-saving thing necessary. I'm sure there's some degree of that, but that the screen is so successful that actually after 20 odd years of screening data, more than that probably, there is evidence that it can go to 2 years. Now, if there's a whiff of retinopathy, they will call you back more frequently, okay? And there's nothing you can do to observe it because you can't see it, okay? So your normal Specsavers or optometrists won't look with a camera behind your eyes. I check for glaucoma and things. So it is important that you do go for that eye screening. But there is evidence that 2 years is actually enough. And the only time I would say go back sooner is if your diabetes, HbA1c or your glucose level was changed significantly. Okay, then ask for maybe an earlier eye screening appointment. But if your diabetes is well controlled and you've had that screening for a long time and everything's normal, 2 years is actually okay. Okay, so carbs, yeah, because carbs are nice. Carbs, you know, and I've had exactly this conversation with my brother and my husband today, because people layer carbs. So they have cereal for breakfast and a bit of toast or a bit of orange juice, and then they have a sandwich, and they have, and carbs aren't bad. So we don't want to be thinking that carbs are bad, but generally between 130 and 200 grams of carbohydrate is enough to maintain your carbohydrate levels. Okay, if you have diabetes, your response to that will be to produce more insulin. Okay, and you may not use all that insulin, so then, as we remember, it's going in to that liver as well. Okay, and if you get a fatty liver, you can get high cholesterol as well. So all of these other metabolic syndromes are starting. So carbs aren't the devil food, not at all, but it's in moderation. So if you're like my husband and he likes pasta, he would have chips and maybe a bit of garlic bread. So you would have just one of those, okay, because it's layering those carbs. Now, there's a really, really good website and a really good app and books called Carbs and Cows. You don't have to buy it, but it's worth looking on their website. That will give you a really good insight into what carbohydrates are. So please don't think that it's bad for you. And the better carbs are the less refined ones. So your brown bread, your brown rice, things like that. They take longer to digest, so they don't spike your blood glucose like white bread, and that does. Okay, so again, it's looking at the total amount of carbs that you eat and seeing what you can swap them out with. You know, if you reduce your potatoes, what can I have instead? A bit of broccoli, you know, whatever you can replace that with. Okay. So remission, weight loss on remission is the biggest impact, Abdul, which is why Roy Taylor's work is so successful. But people don't need to lose hundreds, you know, of kilos or massive amount. 5 to 10% is often enough, and you don't need to be particularly overweight either. Just 5% of your weight is you're going to achieve potentially remission. But it's changing that lifestyle. Again, looking at the carbs. What can I do? We know that carbohydrates turn to sugar. Okay, so what other alternatives are there? And that's a whole nother session, Vicky, that we could do for a whole day, couldn't we? Carbs and cows is your best resource. Okay, and also Diabetes UK will have lots of information on carbohydrates, and I can't emphasize that the work that Diabetes UK have done with Roy Taylor is really worth the read. Okay, but again, it's looking at how possible is that to achieve, and it's not possible for everybody, and they shouldn't be berated if they can't achieve that. Okay, vegan, again, whatever works for you. Okay, whatever works for you to lose weight, to get your HbA1c down, gold star, you know, and there's no one diet that fixes everything. If there was, we'd all be on it. Okay, and you know, if you can't feel your tips of your toes, it's not normal, Ali. So go and ask what your HbA1c is. Have you had your foot check at your surgery? What's your blood pressure? You need to go and find those out, okay? Because generally, if you've got any sort of loss of sensation in your toes or in your fingers, it generally suggests that you've got a higher glucose level. So please go and get that checked out and ask. After this, ask what your HbA1c is. When did you have your foot check? Okay, if you haven't had it done within the last year, please ask for it. Ask for your blood pressure as well, and ask for a medication review. Pre-diabetic, I tried to lose weight. Oh, weight loss again is a whole different thing. And with the Asian population, you have a lower BMI to develop diabetes as well. So your genetic makeup, where you store the fat, is generally where we don't want it to. So your BMI at diagnosis is often lower than our white Caucasians. Okay, so it's, I would look at, if you're pre-diabetic, go onto the Diabetes UK website. I think Vicky's put that in the chat as well. And just look at what alternatives, what can you do? Okay, how many carbs am I having? Because it is the layering of the carbs that's putting that insulin resistance there as well. So we've answered that. Okay, and I think how can you lower your HbA1c if you don't need to lose weight? By looking at what your carb intake is, what medication you're on, and making sure that you're on the right medication as well. So if you're following everything, you don't need to lose weight. And I've got a cousin who's a normal weight. Okay, she doesn't, when she told me she was type 2, are you sure? But we do get normal weight type 2 diabetes. Okay, particularly in our Asian population, because those genetic genes. So just look at the medication and ask for a medication review. So, and how to lower your HbA1c, and have that target in mind, what you want to get to, what you are now, and what you want to get to, because that will help your healthcare professional work with you on that. Okay. Have we answered them all, I think?
I think so. I think that's all of them.
Excellent.
Steroid
therapy, well, yeah. If steroid-induced diabetes is different to type 2, but you can have type 2 diabetes, go onto steroids, and then find that you've got type 2 diabetes, which is why we don't diagnose people on steroids with HbA1c. So if you're on long-term steroid therapy, it's likely that it's steroid-induced diabetes, unless you've got a past diagnosis of type 2. But steroids will push your glucose levels up just because it makes your liver chuck out a load of glucose. Okay, so that's why that's why you get higher levels, whether you're type 2 or steroid induced. Intermittent fasting, again, if that works for people, I've had colleagues, particularly postmenopausal colleagues, who have tried intermittent fasting, had great results. The reason I get up in the morning is to have breakfast, so it wouldn't work for me, but I could easily cut out my carbs. Do you see what I mean? So it's what works for those individuals. Okay, so anything that works is good. Okay, and if you're talking about diet, it's what works for you, what you can afford, and what you can stick to. Okay, it's no good me telling a family of 5 whose mum has got type 2 diabetes to go and look at and cook fresh food, and if their budget's not going to stretch to that. Okay, so it's looking at what people can afford and what people can adapt their lifestyle to. Giving them education, that's great, giving them the information, but actually it's personal choice. And please remember that when you go and see your healthcare professional, it's your diabetes, it's your journey, it's you when you walk out that room, and you've got to manage your diabetes for the next however many weeks, months. Okay, so please, take the tips on board, find out what your diabetes is doing, but at the end of the day, it's your diabetes. And Karen, the same as I said to the other lady, it could be linked to type 2 diabetes, so please go and see your GP or practice nurse. Make sure you've had that annual review, and make sure that you've got an up-to-date HbA1c and you're getting that medication reviewed. Okay. Sickle cell trait, we can't use HbA1c to measure your glucose control. Okay, so because your red blood cells are a different shape, okay, so they don't attract glucose in the same way. So we would get false results, and that might be false high results or false low results. So we could be treating you according to a result that's false. So there is another test that we can do with that, and that's fructosamine, but that your GP would have to request that. Or sometimes we ask people to go on the Freestyle Libre or the CGM, which gives us a predicted HbA1c, which is better than relying on nothing or a false HbA1c with sickle cell traits. Okay. Sorry, I've got something in my eye. Are we okay? Have we answered everything?
Yes, we're all up to date.
Excellent. Brilliant. Well, I really hope you enjoyed that. The test is fructosamine. Fructosamine. And do you know, I'm pretty sure, again, if you go onto the Diabetes UK website, it will be on there. Everything's on their website. Okay. So a low HB, a hemoglobin, will mean that you often get a higher HbA1c because there's actually less blood cells to stick to, so it comes up with an elevated HbA1c. Okay. So we take that with a little bit of a pinch of salt. We can still use it, and we can use it for comparison, but that's why when we do HbA1c, we also do a full blood count, liver function and kidney function as well, because it's all taken as part of that puzzle. That's it, fructosamine. Harry's put it in there for you. Okay.
Tracy, just to answer your question, we will be sending out emails at the end that have sort of evaluation forms in there. So please do fill those in, because that's really great for us to hear from all of you about the event and about anything else that you want to kind of hear about as well. But in terms of a sort of certification, Harry, correct me if I'm wrong, but I don't think we would do.
Actually, this is a question which we have been asked before, and we can provide sort of just, it is just an A4 sheet. It'll just say the length of the event. The best thing to do, if you could email us directly, you'll get an email shortly with ways to contact us. If you email us directly with that request, that's the best way to do it. Yeah, not in the chat, please. Just send us an email to the email that you'll be getting in about half an hour's time.
Thank you all. And if you do have any healthcare professionals, or you are a healthcare professional, then this is what we teach on pit stop and pre-pit stop. Okay. And it's an eye-opener for a lot of our GPs, practice nurses. So, you know, and we you know, they provide that training for them. So, you know, and it's, I say, I'm diabetes all the way through. Don't know a lot about anything else, but yeah. So I'm glad you've all enjoyed it. So.
Brilliant. Well, if there's no further questions, then thank you once again, everybody, for taking some time out of your day to attend this event. Like I say, we will be sending out emails with evaluation forms on, so please do fill those in. They are really useful. Harry's put in the chat as well some information about another event that we've got coming up on the 2nd of July, all about diabetes and kidney health. So if you're interested in learning more about that, please do follow that link, sign up to that one. And if you're on social media, please also follow us on Facebook, Twitter, Instagram, whichever one you use. It's just a really great way to keep up to date with what we're up to. That's it for the questions. I just saw a couple more messages pop up. Yep, I think we're all up to date with the questions. But yeah, thank you once again, everybody, for attending. Please do fill out those evaluation forms and have a lovely rest of your day. Take care, everybody. Bye-bye.